Thank you very much for the introduction. Ladies and gentlemen, I'm going to talk about two procedures for presbyopic treatment using the Technolas laser, the intracore and the supracore procedure. Here are my disclosures. The intracore procedure, most of you have seen some of the lectures about it or even done it yourself, is an intrastromal refractive treatment. We are not doing any incisions or flaps. Cut design stromal depths depend on refractive error. The duration is around 20 seconds. So far we have done in Heidelberg around 300 procedures, and I will give you an update on the CE study that has been started more than 3 years ago. So we have now, for this controlled group, 36 months of follow-up. This started in July 2008 study, and it was a multi-center study. 25 patients were from our group at that time, and I will show you the results over 36 months now. Only one eye was treated, the so-called non-dominant eye. And here you will see directly an overview about the results. You can see that the preoperative hyperopia refraction between 0.25 up to 1.25 diopters was the inclusion criteria, maximum of 3/4 of a cylinder, and that's all. You should not exceed this kind of area for the intracore procedure. And you can see the uncorrected near visual acuity in LOCMA was 0.7 pre-op, and then increased after the surgery by 4 to 5 lines to 0.2, and even after 3 years it was 0.1 LOCMA. So there was a significant increase in uncorrected near visual acuity. At the same time, the uncorrected distance visual acuity was stable or dropped a little bit in average, but in individual cases it dropped a little bit more. And you see also here the results for distance-corrected near visual acuity and the other acuities. We achieved a slight myopic shift from like 3/4 of a diopter on average to a quarter, and after 36 months it was like half a diopter. So the refractive error in general was not so big. Here you see that the distance acuity was only affected by one line, and we're talking here about patients starting by minus 0.1, so in decimal 1.25 visual acuity, going down to 20/20. The uncorrected distance visual acuity, as you can see here, 100% have after 3 years 0.3 LOCMA or better, and you can see the development is quite nice over time. Corrected distance visual acuity, as I said, dropped a little bit, but we're talking here something about 0.1 to 0.2 LOCMA units. The increase of uncorrected near visual acuity is very pronounced, and as I said, on average 4 to 5 lines. Here you see the cumulative data of the uncorrected near visual acuity. Around 95% achieve 0.3 to 0.4 uncorrected near. And here the distance corrected, so there's not much influence of residual refraction, as you can see here. Let's go further. Important is that the patient has already a visual acuity, for example, of 0.2 or something. If you add up 4 lines, then you will get to a very good reading acuity. If a patient has, for example, a visual acuity of here 0.63 or something, and you add 4 lines, then you will add up here, so he may not be satisfied. So you have also to look at the preoperative uncorrected near visual acuity. The retina reading charts testing showed a little bit improvement, but this was due to the fact that the patient could read smaller print. The pentacam showed the results here. A central steepening in the middle gives you the near acuity. Here in this case was an addition of 1.6 diopters. The Q value goes a little bit to asphericity, negative asphericity. We don't know if this has also a big impact on that. Stray light measurements were equal between preoperative and postoperative LOCMA examination and didn't change over the 3 years. And the cellular cell count also remained stable over 3 years follow-up. Let's go further. The refractive correction was stable over 3 years now, 4 to 5 lines gain, but we have a small myopic shift. 80% to 90% were without reading glasses, so far no regression. It's minimal invasive. However, there are some side effects, a small decrease in contrast sensitivity, but also a loss in corrected distance visual acuity, and this was up to 12-15% with loss of 2 lines. However, as they are binocularly, they were fine. We have some halo sometimes around light sources. Most of them go away, but sometimes it can also be longer. The only problem is that you don't have a real option for complete reversibility or for corrective treatment. Let me just summarize also quickly the European data from the SuperCore study. This is done with the excimer laser, not with the femto laser. This is a corneal procedure with a presbyopic algorithm used in eyes with hyperopia, but also emetropia, myopia, and also Dr. Enge has shown in pseudophakic eyes some approaches. This is a profile for both eyes usually is done, and you will see that the range of aberration optimized treatment here is much bigger than if you just look at standard bifocal optics or the normal near treatment in other treatment zones. The small Centi study, 23 patients were followed up here for 6 months. They got bilateral LASIK treatment, no monovision, it's the same treatment for both eyes. And after 6 months, the nomogram of the sphere was adjusted. Here are the spherical equivalent and also sphere and cylinder. You see they were on average hyperopic and afterwards slightly myopic with a refraction. Here you see that also, and this was stable over the follow-up period of 6 months. If you look at the monocular or the binocular corrected distance visual acuity, you can see that 89% achieved the best corrected visual acuity of 1.0 and 100% even binocularly. 0% lost 2 lines after 6 months follow-up. There were some losers in the first couple of weeks, but this is more due to surgical problems or to dry eye symptom. Uncorrected visual acuity was in 85% 0.8 or better, binocularly in 91% 0.8 or better. So patients have in general quite good distance and near acuity with this.